Hi, everybody. I'm here to talk to you today a little bit on a topic which is very interesting for me. It's decision making with guided implant surgery and basically using evidence to try and see whether you are making the right decisions when you are doing guided surgery. My name is Dr. Varun Acharya. I did my dental school in Savitha Dental, which I graduated in 2012, which is in Chennai, India. I moved on to NYU and I had done postgraduate prosthodontics, which I graduated in 2012. This was a fantastic place with a lot of the greats you've heard of as faculty at NYU. I moved on to do a maxillofacial prosthetic fellowship at the MD Cancer Center. This is a phenomenal institution. It's huge. It sprawls many city blocks, and these guys invest millions of research into cancer, and they're truly committed to the cause of making cancer a thing of the past. I then came back in 2013 back to India. I practice now at Acharya Dental, which is in Chennai. So without further ado, let's get to guided surgery. So guided surgery has been gaining popularity since the mid 90s. Why exactly since the mid 90s? Well, we have to think about what is happening since the mid 90s, which could have resulted in this sudden surge of popularity. Basically, computers. Computers became cheaper and the cost of high quality image acquisition was reduced. The amount of radiation we were exposing our patients to was reduced, and the amount of data you got from a simple CBCT was huge. So you now had all of this information, which really facilitated the big boom in guided surgery. And a CBCT itself, we're all familiar. It gives you bone volume, no doubt, bone quality, yes, anatomical structures, and any pathology if there is. One of the things is if you have to remember in a CBCT, it doesn't really give you Hounsfield units that you would need a medical CT. This gives you something called gray values, but it does give you an idea about how dense the bone is or the quality of the bone. One thing we tend to forget with CBCTs, it also gives us information about the future restoration. And that is if you have the right planning software. The CBCT by itself doesn't give you that, but if you're plugging it into the right software, then you can plan the future restoration. And that is something which is very useful, and we're going to talk about that today. What are the advantages of guided surgery? You can plan and optimize the implant position in a restoration driven placement manner. What does that mean? You are not placing the implants where the bone is, but you are placing the implants in the ideal location for where the future teeth are going to be. Because remember, patients come to you for teeth, they don't come to you for implants. So that is something to keep in mind. And that is something which guided surgery really gives you very, very beautifully. And it helps you follow the principle of begin with the end in mind. What is the end? The end is a functional, beautiful aesthetic prosthesis. And this helps you plan from the very beginning, even before you make your first incision. You've already decided what the end goal is going to be, and that is your major advantage of guided surgery. What are the types of guides you have? You can have non-limiting, partially limiting, or completely limiting. Now, if we look at these words on their own, it almost seems like non-limiting is the best and completely limiting is the worst because, we like freedom. Who wants to be limited, right? We don't want to be limited. But let's look at exactly what those mean. So a non-limiting guide is something like this. This is done very, very simply. This patient was bilaterally edentulous in the posterior regions. So you can see on this right side, this is what it looks like when this stent, this is just a vacuform or a suck down as you may call it on a stone model. And this right side has the radiographic markers. The left side has the perforations just for the pilot drill. And we would use this type of guide initially during the radiographic scan, during the CBCT, and the markers tell us where those teeth are. And finally, at the time of the surgery, we would just remove those markers, make holes in them through the center of the tooth, through the central fossa, and that becomes a sort of very, very basic guide. So it only gives an indication of the ideal implant location, but it does not help with the angulation. Angulation, you can still make an error. You might go straight in and you may still do this or this, and you may change the angle of your drill unfavorably. So it's a non-limiting design. So the real drawback here is it gives you too much flexibility in the final implant position, and that's really a problem sometimes. A partially limiting design is a little bit better. Here, only the first drill is directed by the guide, and the remainder of the surgery is done completely freehand. And the problem with this is the angulation still cannot be restricted effectively, because imagine if you're going in with your first drill and you're made a perfect osteotomy, then your next drill, you have to take out the guide and you have to use the wider size drill. And at this point, you might make a mistake and you may change the angulation. So watch out for the angulation, which may change in a partially limiting design. This is a little better than the completely free guide, which I showed you earlier, but this still has drawbacks because you can make a mistake. Some examples of this is in D'Souza's paper, but basically buccal tubes in acrylic is one way of achieving this type of guide. And you would make this beforehand in the stone model, and you would make this typically in cold cure acrylic, and you would only use the first drill to make the initial pilot osteotomy. And after that, you have to disconnect this guide and then use the remainder of the drills. You can even make this, and these are typically made on the cast, but you can even make this with using some PVS material. And this paper, which we've highlighted down below, gives you a good idea of how exactly to use a drill of this kind, use a guide of this kind. And next, we come to CAD/CAM based surgical guides. These are the fully limiting guides, right? They do not allow you to change your plan midway as long as you have the guide on. So you use CT data to plan the rehab, and the planning is done on software. And this gives you better visualization of the bone available and the anatomical issues, because here you're going to plan till the very end from the very beginning. So it facilitates flapless surgeries, right? This is a very, very strict rule which cannot be misinterpreted in any other way. But you must use, if you're planning to do a flapless surgery, you must use a CAD/CAM based surgical guide. Do not do a freehand type approach if you are doing flapless surgery, because you have no idea where the bone is in spite of the CT, and you need to see the bone to place your implants. It is a huge risk if you're doing flapless surgery without a CAD/CAM based surgical guide. I would recommend that you do not do that. You can make pre-surgical provisional restoration. So this is a very, very useful concept. If you have a set indication or a set location of exactly where your implant is going to be, since you now have that information, it's going to be very easy for you to make your provisional beforehand. You keep the provisionals ready, and once your implants are placed, you would place some abutments on them. It could be either cement retained or screw retained, your preference, and the temporaries are typically relined to fit that implant placement and that abutment which you have selected. Normally, some amount of relining is required, because I don't believe manufacturers have yet achieved an exact precision where the temporary can be perfectly seated, especially when you're doing multiple units. So you should allow for some variation. So that's why I say you will get a shell of your temporary, and you can then reline it with some acrylic to the abutments which you've placed on your implants. But you're going to see that you're actually very, very close. However, doing CAD/CAM based surgical guides does require some special training. You need to have someone guiding you the first few times, and making sure that you select the right drill size, you make sure you select the right patient, because there's certain indications where you cannot do guided surgery, and we're going to talk about that as well. But yes, some amount of training is needed. How do you fabricate this fully limiting CAD/CAM guide, right? You have to fabricate the radiographic template. The patient needs to have something in their mouth to have the CBCT scan, except in certain situations, maybe when you have only a single tooth missing and you're planning a CAD/CAM guide for that type of situation. Your landmarks are already there. You have a tooth on the mesial, you have a tooth on the distal, you have the opposing occlusion. So you don't need a radiographic guide for that. But if you're missing multiple teeth, then it's very, very useful to have a radiographic guide to plan your placement. How is the radiographic guide made? Let's say you have an edentulous patient, then a denture can be duplicated and you can put radiographic markers on them. That's one way to do it. Or if you have a partially edentulous patient, you would again just make a simple sort of wax up in a bite rim, and you can add lead foil or lead markers, and that would be your radiographic guide. So you fabricate the radiographic template, you make your CT scan with the patient wearing the template. You have to indicate to your scan center that you need this scan done with the patient wearing the template, and you need to show the patient how to wear the template. That becomes a challenge. Sometimes, if you've just given the patient the template and you said, figure it out in the scan center, more often than not, there's going to be some kind of issue because they're not going to be able to place it properly. Following a perfect scan, you need to do planning on the software. Finally, when the plan you've received your plan from your lab or the manufacturer, you approve the plan. It's usually in a PDF. You approve it, and then it goes to fabrication, which is basically 3D printing the guide and making sure it passes quality control, and then they ship it out to you. So what are these types of guides? One we spoke about was the pilot guide, where only one type of drill goes in. Only one drill goes in. Then you have a tooth supported guide, which you have most of the teeth holding onto the guide. These are very stable because teeth are relatively fixed in position, and they will hold your guide really well. The next is a mucosa supported guide. So mucosa supported guide, you are not going to raise a flap. This is for flapless surgery. So this sits on the mucosa, and you anesthetize tissue, and then you would use some sort of pins to secure the guide in place. And finally, you have a bone supported guide. A bone supported guide, you are expected to raise a flap, visualize the exposed bone, and then place this guide. When is guided surgery possible? Now, remember I told you there are certain situations where guided surgery may not be possible. If someone has restricted mouth opening and you're trying to place an implant in, let's say, the lower right second molar region, the mandibular right second molar, and they have restricted mouth opening, you are going to have a very hard time with guided surgery, only because, remember, the guided surgery drills are longer than your regular implant drills, because they need to go through the guide, touch the bone, go through the bone till the length of your implant. So they are going to be longer. They are definitely longer in size. So difficult posterior regions in a patient with reduced mouth opening, that may be a challenge. So you need to make sure that you have enough interdental clearance to facilitate guided surgery. So that comes about in the diagnosis phase. And what really we need to look at is, what is the evidence on guided surgery? Is it making us better practitioners? Is it giving our patients better results? We need to ask those questions. So this is my favorite slide, which talks about accuracy and precision. You could be on the upper left over here, which is low accuracy and low precision, which is missing the target every time. You could have low accuracy but high precision, which means you're hitting the wrong place but consistently every time. You can be high accuracy and low precision, which means you're kind of close to the bullseye every time, but not always. And then really what we want to achieve with a CAD-CAM based surgical guide, and this most often you are going to achieve it, is a high accuracy, high precision situation. Let's look at some evidence. So this was a paper which studied the factors affecting the accuracy of guided implant surgery. And this is a high quality of evidence because it's a systematic review and a meta-analysis. And what basically is guided surgery? It's using a static surgical guide, and you're trying to reproduce the virtual implant position, the position which you planned or your technician planned on the computer. And remember, this is fully limiting. It does not allow for your intraoperative modification, meaning you cannot change the plan or change the location of the implant during the surgery. If you're thinking of changing your mind and you started guided surgery, the guide has to come out, and only then you can change your mind, so to speak. Let's look at the shape of the maxilla and mandible, right? They are wildly different. So let's see if the maxilla and the mandible play an influence, or at least the shape plays an influence on accuracy. The guided surgery on the mandible has more angular accuracy, meaning you are not going to have tilting issues so much in the mandible. One of the reasons may be, of course, you're operating in direct vision in mandible, and also it's just the shape of the bone and the fact that it's denser bone. Whereas in the maxilla, it's more like a circular curve, and it's also softer bone, which can lead to more errors in the maxilla. If you were to compare partially guided and fully guided, which one is going to be more accurate? If you were to guess and you guessed it right, then fully guided is more accurate than partially guided. Why? Because of the same reason I explained earlier. If you're going to have a single little drill, which is the pilot drill, and you're going to place that in and you take out the guide and then you finish the surgery freehand, of course, the potential for angulating incorrectly is quite high. But fully guided, it's essentially like your hand is being held and you cannot change the direction midway. And flap versus flapless, what is more accurate? If you raised a flap and saw the bone and placed your guide on the bone and did a guided surgery, or if you placed it on the mucosa and did a guided surgery. Studies have shown that actually flapless is more accurate. And let's think about why. Remember, raising a flap and exposing all of the bone in a full arch is not a very easy task, right? And once you achieve that, there may be still some soft tissue on the way, which may be slightly affecting the seating of your guide. And that's really a problem. So, if your guide is not seated perfectly, then you will have some level of inaccuracy. So, but if you're doing it right on the tissue, then that's something which you're not so reliant on raising a flap and clearing out all of the excess tissue. You're just sitting right on the tissue, like in this picture down here, and you stabilize it with your pins, and you can go ahead and perform your surgery. So flapless is more accurate than when the flap is raised. What about age? Does age play a role? Is guided surgery going to be better for the younger guy or the older guy? Not really. Age has no influence on the accuracy of the guide. And what about fixation screws versus no fixation screws? Let's say you had a mucosa supported guide and you held it in with these fixation screws, which is what you see up here. Versus if you didn't use a fixation screw, then fixation screws are more accurate, because remember, because of fixation screws, the guide cannot move. It is going to be completely locked into the bone, and that is something which is going to give you a lot of stability for the guide and therefore less mistakes. So let's look at another paper, and this one looks again at the accuracy of guided surgery, and they compared cadavers, clinical, and in vitro studies. So typodont, a patient, and a cadaver, and they analyzed to look at the accuracy between all three. And what were the things they measured? They wanted to see how much deviation is there horizontally, how much deviation is there vertically, what about the angulation. They checked all these things. So with apical horizontal deviation, which is basically this X value over here, typodonts were the most accurate, then clinical, then cadaver. If you look at angular deviation, which is B over here, typodonts were the most accurate, then cadaver, then clinical. And horizontal coronal deviation, there was really no difference between the three, which means horizontally the position more or less remained the same between all three. Implants placed with full guided surgery had more accuracy than those placed with half guided surgery in all of these three metrics. So horizontal coronal and apical coronal, and even the angular deviation. So this goes back to what I mentioned earlier. But why bring up the cadaver, the clinical, and the in vitro studies? Essentially, going back a few slides, if we were to compare these three, of course, we're going to get the most accuracy in a typodont, right? Because you don't have all the limitations of the musculature, the mouth, the saliva, the patient complaining, etc. So the most accurate would be the typodont, and the patient cadaver situation depends on exactly what we are measuring. And that's what the evidence shows us. So remember that there may be some small amount of accuracy, but that accuracy is going to be within acceptable limits. Another paper, this again looks based on the type of support, and they basically said the bone supported guide, the type which you're going to raise a full flap, that is going to be least accurate compared to the tooth and the mucosa supported. And that goes again with what we were talking about earlier. It's essentially when you're trying to raise a full flap, it's not a very easy thing to do, and that may reduce your accuracy. But there are times when it is indicated to raise a full flap, especially when the bone is very, very minimal and you want to have a visualization of the bone. So it gives you better visualization and depth control. So you need to be very specific. It's a case selection or a diagnosis. You need to make the proper diagnosis and say, for this patient, there's very little bone. I'm comfortable using guided surgery, but I most likely need to raise the flap because I want to place my implants and maybe do some GBR, or I want to visualize exactly where the implant is going in because the bone is so minimal. You need to make those decisions and inform the lab yourself. There's no significant difference between tooth and mucosa supported guides in angle deviation, deviation at the entry point, and deviation at the apex. So this is one study which basically said for these very, very important criteria, there was not much deviation between not much difference between a tooth and a mucosa supported guide. For me, my personal preference, if I can get a tooth supported guide, that's of course more preferable to me because a lot of times I can avoid using crestal pins and other kinds of support, and the teeth will hold the guide in place fairly rigidly. Heat generation is a big concern in guided surgery. And why exactly is that? When we do our regular implant placements, we have a lot of irrigation going into the osteotomy because that is connected directly to our saline, and we have the entire area nicely irrigated. Remember, in guided surgery, it's a fixed osteotomy hole and it's a very precise fit of the drill into the guide. How do you make sure that enough irrigation is reaching the osteotomy? Of course, we don't want to exceed 47 degrees Celsius because that is the temperature at which the bone cells start to undergo necrotic changes. So we want to make sure that enough irrigation is reaching the osteotomy. How do you make sure that you do that? I'm going to talk about it, but let's look at the evidence about heat generation. So bony turnover affected by hyperemia, necrosis, fibrosis, and osteocytic degeneration and osteoclastic activity. So these 5 things are essentially very harmful to bony turnover, and the amount of the necrotic zone you have is basically proportional to the amount of heat generated. So if there's a lot of heat continuously, then you're going to have a bigger necrotic zone. And remember that a high temperature for a short duration, meaning you've reached 50 degrees Celsius just for a minute, has the same effect in terms of heat generation as 47 degrees Celsius for 5 minutes. So you need to be very, very careful and make sure that you do not exceed high temperatures of the bone. One of the things you can do in guided surgery is, since you have a very precise fit of your drill into the osteotomy, you can raise your drill and you can allow irrigant to go in every time. So it's kind of a pumping motion while you're doing your guided surgery so that enough coolant reaches in. But if you go just directly and block the entire irrigant from getting in, then that's going to be a problem and you're probably going to be causing a lot of heating. What are the factors affecting heat generation? Let's look at all these things, right? The operator, the amount of pressure they're using, what is the speed, what's the duration, does the manufacturer of the drill matter, does the material used to manufacture the drill matter, doesn't having an old or a used drill raise temperatures? What about irrigation, and what about the implant system? Let's look at all of these things, whether they affect heat generation. And these are the patient-related factors. What about the site? Is it going to be warmer in the maxilla or warmer in the mandible? What about the thickness of the cortical bone, the patient's age or the density, and the site itself? Let's look at all these factors to see how they affect heat generation. So, drill design. Surprisingly, the smaller drills, the 2 millimeter twist drill, actually has the highest temperatures, and it can be, you can read about this in the paper which I've quoted. And the 4 millimeter diameter tri-flute drill, so this would be, the third or fourth drill which you use, has less heat than the 2 millimeter twist drill. So now, if that's the case, why don't manufacturers just supply you with one drill for, let's say, a 5 millimeter implant? Why bother going through that sequential sequence of smaller, little wider, little wider? The main reason we still perform osteotomies this way, even though the 2 millimeter drill causes the highest temperatures, is mainly because if we perform an error during our osteotomy, we can still correct with the wider diameter drills. If you had to start with the final drill size and now you have made a mistake and it's not in the right place, you have to abandon, possibly bone graft, abandon the procedure, and revisit in 3 or 4 months and do the procedure again. And that's a very difficult conversation to have with the patient. The material of the drill, not critical. Whether it's made out of stainless steel, zirconium coated with steel, titanium nitride, what have you, ceramics, etc., doesn't make a difference in heat production. What about the sharpness? You might think that bone drills produce higher temperatures. They actually do not in this study. But remember, in evidence-based literature also, there's going to be a lot of disagreements, and Scorano disagreed. I would say that do not use worn drills. Talk to your manufacturer about how long you're allowed to use a certain drill before which you need to change it. It may be that worn drills don't produce higher temperatures, but you're going to be spending a longer time making the osteotomy, and as a result of that, you're just going to be exposing the bone itself to more trauma. Remember that making an osteotomy is a form of trauma, right? It's a surgically induced trauma. So you would want to reduce the amount of time you are spending in a site. And if you have worn drills, you're automatically spending more time. So get rid of those worn drills as soon as possible. And one of the things you can do is use something like this, a chart where every time you use a drill, you make a little check mark and you move on. As soon as it reaches a certain number, whatever your manufacturer tells you, you can move on and then order a new drill and replace it. What about pressure? If both of these guys were renowned implantologists and they were doing guided surgery, and of course the big guy is going to be placing a lot more pressure than the little guy over there, do you think there would be a difference in the amount of heat generated? Actually, no. Axial loads of 5, 8, 15, and 20 newtons has no effect on the heat produced during drilling in the cortical and cancellous bone. So both of these guys are going to produce almost the same amount of heat in the osteotomy, irrespective of the pressure they use. What about irrigation? Do you need fancy irrigation systems? So according to Bennington, no, you don't need it, and there's no justification for using these fancy irrigation systems. But Strabak basically said that there's no irrigation is the worst, obviously. The next is external irrigation, followed by internal. But he said that if you combine external and internal irrigation, then you're going to get a very good cooling solution for your osteotomy preparation. One of the things which some practitioners also recommend, and something I do as well, we make sure that our saline solution's been kept refrigerated so that it's cold at the time of using it, and that helps to drop the temperature as well. Temperature within the osteotomy. Of course, the deeper we go in the osteotomy, the less chance that you have irrigant to reach, and the highest temperature was recorded at 12 millimeters depth, which was 37.7 degrees Celsius. And sequential drilling was more gentle. And remember, we spoke about this just now, but even though the twist drill or the 2 millimeter drill produces the highest temperature, we still prefer to do sequential preparation because that is a more gentle way of doing it. It's more predictable and you have more control. And there is higher temperatures as we do these graded burrs, but that's still something which we need to do just for the sake of a fail-safe, if you will, just to make sure that we don't make an error which we cannot recover from. So What about the flap versus flapless, right? So there's no difference in temperature between flap and flapless, but of course the researchers would have made sure that irrigation is reaching the site effectively. And the highest temperature which was recorded by Misr was at the depth of 9 millimeters when the splint was used. So as you go deeper and deeper, remember it gets warmer, remember to keep that irrigant going. What about different surgical techniques which we can use? Of course, you've heard of bone condensing, which is the Versa system or the Densa system. There's less temperature than conventional. This is where the drill is going in reverse. Piezoelectric, very convenient device, but does produce more heat than conventional. And what about drilling time and bone quality? Slow speed takes longer, but it does not increase temperature. Remember that. If you are going at a lower RPM, do not worry about raising the temperature with slow speed. And when we look at speed, actually, spiral burrs are the fastest, and the spiral burrs are what we traditionally use for our osteotomies. Then you have a trephine, which is used when you have an implant failure, and then you have a piezo. So the spiral burrs are the fastest, but in terms of temperature, spiral burr produces the least, trephine is hotter, and piezo is the hottest. So remember when you're using a piezo that you need to be careful that you don't generate too much heat, especially because the piezo is also quite slow in its working. There's higher temperatures in cortical bone, and these are the things we need to kind of remember for the evidence of guided surgery. Basically, don't let the site get too hot. Remember the limitations of your guide. How does the planning software help? You can do fast planning with the right planning software. What does that mean? You have a lot of implant libraries available to you. Depending on the planning software you're using, you can say, I have implant number X or implant name X, size Y, and I need that exact virtual implant. Your software should have that available to you. You can achieve the ideal aesthetic result, the ideal end result you can get because you've planned it ahead of time. You will know where the nerves are so that you don't collide into the nerves. And it'll also give you a collision warning, making sure that your implants are not too close to each other, because that would give you a poor aesthetic result and may end up even with an implant failure if you're too close. It'll help you preserve anatomical structures. So anatomical structures like this, if this situation happened, it's quite tragic. We don't want to be making an osteotomy into the root of a tooth. So guided surgery will definitely help you prevent that. And you can, of course, assess bone quality and quantity, and it really makes the surgical procedure overall easier, right? It takes a lot of thought process. If you're doing a full arch such as this, it would require a lot of planning, and of course you still need planning with guided surgery, but the actual surgery itself is a lot more stressful if you're not doing guided, because you have to keep checking your angulation multiple times. You have to keep checking, making sure that you're in the right place. With guided surgery, most of the stress you've eliminated beforehand, and then during the actual surgery you're good to go. So these are the processes which you need to follow to facilitate guided surgery. So let's look at that. You need to check the opening of the patient's mouth. You need to diagnose everything. Make sure you have enough bone thickness, enough distance between teeth, and also check if there's a lot of metal in the oral cavity. You may have scatter that may affect the quality of your CT scan. So make sure that that's not going to be a problem for you. Finally, an impression is made. This could be actual analog impression with impression material, using PVS preferably, or you could do an intraoral scan as well. Next, you need to make a radiographic template, and this is usually when you're missing multiple teeth or all teeth, and these radiographic markers, these little balls which you see over here, can be used to mark exactly the location, because this will show up on your CT scan. So right now you will then do your CT scan, and if you're doing a partially edentulous case, it could be a simple suck down like this. I prefer to do this over a wax up and duplicate the model and then do the suck down. And then I like to actually add, the backing of an X-ray film, the silver backing of an X-ray film, just typically lead. You would add that and then get your CBCT scan. It's also recommended to use gutta percha. There's just lots of ways of doing it, which everything would work quite well. And finally, a totally edentulous case, you would again ideally do this with a proper denture setup. And you can also duplicate an existing denture and use that as your radiographic template. Now there's something called matching. This is very critical. You have two sources of data. One source is your intraoral scan or your impression of the mouth, and the second is the CBCT. You need to tell your computer how to make these two meet, and that is what the matching process is. Typically, you wouldn't have to do this. Your lab would handle this for you, but once they match, they would mark 3-4 points on the scan, 3-4 points on the CBCT, and marry the two together. So now they have one file, so to speak. So this matching, this is a recommendation by B&B on where to place the markers for ideal matching. So you kind of get a tripod triangulation effect. Once the CT is done, for the CT, you make sure that the template is sitting well. For an edentulous case, you may want to give them a putty index to bite on so that you know that there's no movement. Make sure you're working with a scan center which understands why you're doing this, because we've had issues in the past where we would send for a scan. The scan center would say, hey, you don't need that, just do your scan, and then the patient comes back without the guide in the mouth. That's a problem. Educate the scan center, educate the patient. And finally, there are a lot of settings over here, right? So the standard scan settings is what is going to work. And they will send you the raw DICOM files. This is very important. Scan centers can send you just the image or an image viewer format or the raw DICOM files. Please insist that you want the raw DICOM files, because then you can take those files and plug it into the software. This is the matching process. And finally, the planning process. This is done completely on the software. We get the scan data, we get the intraoral scan data and the CBCT, we marry them all together, and we plan our ideal restoration. Once the planning is approved by the doctor, we make the surgical template. It goes to manufacturing and it arrives to you ready for surgery. It usually is 3D printing to achieve that. Once it arrives for the surgery, you're good to go and place your implant with less stress. So let's look at some of these possible mistakes. One of them is radiographic technique. If you are using the wrong kind of CT scan, or if the CT scan machines are poorly calibrated, which are going to give you a lot of ghost images like this, they are not good. You would need to redo the CT scan. If there's a lot of patient movement, you're going to get a blurry image like this, and that is not useful. Again, you would have to redo the patient scan because you're not going to be able to match the images well. And the placement of the guide is very important. If here you can see in the mandible, the guide is not seated fully on the mandible. The position of the guide is very, very important. It has to be stable. There shouldn't be any gaps. What you see over here, that means the guide is not seated well. Again, here in the posterior, you see these gaps. It's not seated well. And it's a good idea definitely to make these putty indexes to make sure that the guide is seating predictably in the same place every time. Sometimes you may need to do a little bit of trimming to make the guide seat fully, and that's just errors in the 3D printing or the acrylic. You may have to adjust for that. But undercuts may be a problem in the guide. Tissue thickness is something which has to be compensated for if you have an inaccurate guide, and if it may be because the tissue thickness has not been accounted for. And stainless steel drill and peak sleeves, it's not advisable to reuse the peak sleeves too many times, because if they get damaged, then you're going to lose that accuracy. Everything has a learning curve, and initially when you do this, you may feel that it's taking you longer, but once you get used to guided surgery, you're going to be much, much faster. And finally, the long operating time. Don't spend, how to explain this best? The lesser time you spend doing a surgery, the better outcome it's going to be. So if we initially spend a lot of time trying to figure out guided surgery, it may affect your final outcome, but once you get used to it, once you really understand how guided surgery works, and you are able to optimize not just you, but your assistants and the entire workflow, then guided surgery will really work well for you. So very quickly on the workflow, you make the diagnosis, you take an impression, there's a radiographic scan, there's a CBCT, template if needed, files are matched together, planning is done, 3D print the surgical guide, and then you're ready for the surgery. So a tooth supported guide, remember, is held in completely by the teeth. You can use the fixation screws if you like, but typically if I have enough teeth, I don't use them. Mucosa supported guide is the next level over here, usually in fully edentulous or partially edentulous cases. And here it is advisable very much to use the fixation pins to hold the entire guide in place. And a bone supported guide, you definitely need to use again the fixation pins. And here you have to make sure that you eliminate the flap out of the way to make sure that the guide is sitting completely. What are the kit components in the B&B surgical system? Let's look at, before we go into those kit components, let's look at surgery done with another system. And this is just for sort of comparison's sake, so that we understand how the B&B system is different. So this is for tooth number 4-6. The tooth was extracted, socket preservation was completed. Local anesthesia being delivered. The guide 3D printed, and there's a sleeve in place. I found that the seating of this guide was not ideal, so we checked. And I had to do a little bit of trimming to get this guide to seat all the way. Fit could still be better, so I needed to take the next step, and I actually cut off the guide, or at least an edge of the guide. Because if you're not having a predictable seat, then it is not very advisable to continue. Now this seated perfectly, no problem. So this particular system, this is not B&B, this is another company, but they use these spoons, as you can see. And for every drill, you need to change the spoon. So the master cylinder remains the same. That's the part in the 3D printed guide. And then you use these little spoons and you keep changing the drills every time you're making an osteotomy. Now the implant is being placed. Implant looks pretty good. Checking to make sure that we are slightly subcrestal. Now we place the cover screw. So overall, this system is fine. It works well, but the spoons are something which I really don't like because you have to keep changing it every time. So let's look at the B&B protocol of doing guided surgery, and I'm going to walk you through that. And I thought this would be an easier way rather than going through the instrument step by step. Maybe easier to do it this way. So before I continue this video, I have to explain that there is a difference here. If you're placing a 4.5 or a 5 millimeter as the final implant, you're going to get this wider peak sleeve over here. And if it's any implant smaller than that, you're going to get this narrower peak sleeve. But remember, you still need to use those initial drills over here. So to get those initial narrower drills over here, meaning up to the 4 millimeter drill, to get that in over here, we need to use a converter. And you're going to see that in this video. For this one, no need of any converter because this final implant size is going to be less than 4.5 millimeters. Probably going to be a 4.0 or a 3.5. We'll see that in this video. So the peak sleeves can be different. So we use a tissue punch. Now converter again, tissue punch in the back. The tissue needs to be removed. Place the guide again. Now we use the lance drill, converter for the bigger holes. We have made it flat with a flattener and a countersink. This is the guided drill, converter for the back. Again, converter for the back. Once more converter for the posterior. Remember, the anterior doesn't need the converter. Now, once we reach the 4.5 millimeter drill, we don't need the converter anymore. The implant is inserted. You can use this mounter to also deliver the implant. We remove the other side crestal screw, which was holding this whole guide in place. Go through the sequence and place the implant as well. So the advantage of the B&B system, I believe very strongly actually, is the fact that you don't have to use these spoons. So it essentially frees up a hand. If you needed to use these spoons, then your hand is busy, your left hand or your right hand is busy holding the spoons, the other one is holding a drill, and it is a bit cumbersome. I prefer the B&B system because you can quite easily do this just with using the converter for the wider, and that may be the only mild inconvenience, but that's something which your assistant is going to load and give it to you, so you wouldn't have to worry about that too much. This is the planning on the B&B software, and we're going to take you through a planning of an actual case. So we're importing the CBCT. That's step 1. Adjust the image as needed. Now we've imported the scan as well. That's on the right side. Both of these are being matched. We're plotting the nerve, making sure that we do not have any accidents. So very, very critical to plan the nerve or to plot the nerve. Now we actually are beginning with the end in mind. Here's the final restoration. And we are making sure that we are going to do a screw retain crown. So we want an ideal emergence right through the central fossa. And we are adjusting that angulation, making sure we have enough bone buccally and lingually. And now we are drawing the guide. That's the actual guide, which is going to get 3D printed. We have little windows to make sure that we are seated fully and you can visualize. And that's the final guide. That's going to get printed. So here's the actual case, missing 4/6. 3/7 was extracted, by the way. The guide arrived from fabrication with the peak sleeve in place, and here's the surgery. Local anesthesia, checking the guide. It's a good fit. I didn't have to do much modification. Tissue punch. Take out the excess tissue. And go through the drilling sequence. Initial osteotomies. On these teeth supported guides, one of the reasons why I don't like fixation screws is actually because the guide is stuck and you really can't take verification x-rays in between, which is something I still like to do. But of course, if you're fully mucosa supported or bone supported, you need the fixation screw. So here's the actual implant being delivered. Sorry if this video is a little fast, but we are a bit short of time. We're doing the final tightening, making sure it fits. Implant in the right place, cover screw being delivered, tightened. That's it. So that was the initial osteotomies, final osteotomies, implant in place. And that's nice, exactly according to plan. result that we achieved. And this was a CBCT done post-op, and you can see there's exactly where we wanted it to be. Lots of bone on the labial and the lingual, so an ideal implant placement. That's what it looked like at the second stage, I believe. Yes. We removed the healing abutment, made our impression. This was a closed tray impression coping. Nice screw retained crown, just a simple PFM crown. And that was delivered to the patient. Another case, I won't go through the guided sequence, but that's the maxilla, that's the mandible. This planning is in 3 shape. So you can also do this. If you have Implant Studio software, you can do the planning in 3 shape. So you can see how this planning works. We import the scan. That's our CBCT. We've already imported the intraoral scan. We adjust the occlusal plane. Confirm the alignment. Make sure that the matching of the files has taken place well. Mark the nerve. Select our implant, which is going to be a Duravit 3P. Perfectly position the peak sleeve. And finally, we can draw our guide. In this case, we decided not to make it the full arch, just a sectional. We made little viewing windows to make sure that you can see that the guide is fully placed. You can even put your name and the patient's name and whatnot on the guide. So that's the completed guide, and that's the peak sleeve in place. Here we have the guide in place in the mouth. That's the implant already in place. The surgery went off very cleanly. Second stage surgery. And that's the final crown. So you can see actually because of the way the bone is, the implant placement is a little bit lingual, but that's exactly where it should have been because that's where the bone was in this particular patient. But we still are able to achieve a nice screw retained crown. So to conclude guided surgery, you have to understand the potentials and the limitations of guided surgery. You need to know when you need to do partially or fully guided surgery. But if you're doing flapless, remember you want to do fully guided surgery. And you have to adapt your technique and you have to ensure success with the guided protocol. And I think a lot of that comes from the diagnosis. If you diagnose your cases right, I think you will have a lot of success with guided surgery. And that is something to keep in mind. So I do hope that you have found this entire presentation useful. I can always be reached either on Instagram or on Facebook. And please feel free to contact me anytime. And I thank B&B for giving me the opportunity to deliver this small lecture to you today. Have a nice day and stay safe.